So I'll be talking on this topic which I had as a pro-con debate in Mysore South Zone Conference in 2018. So my opponent was Dr. M. N. Shivkumar. So this was the debate I had. So he spoke on the topic that he will not de-escalate antibiotics in culture negative sepsis. So my rebuttal was that I will de-escalate antibiotics in culture negative sepsis. So the debate agenda was we'll cover a bit on the background. So let's get the basics right. So what do we understand about this whole antibiotic and its de-escalation? And we look into the available evidence to de-escalate antibiotics in sepsis and septic shock. There are two studies. In neutropenic sepsis, there is one study and there is one meta-analysis where they have looked into the outcomes of patients where antibiotics were de-escalated in culture negative sepsis. Then we'll touch about procalcitonin as an adjunct to de-escalate. So there were two studies, take home message and rebuttal. So when you look at the background, I think what we need to understand is it is extremely important to optimize our usage of antibiotics. The reason why it is extremely important is because there is growing resistance of or resistance of organisms to infections, and there are no new antibiotics in the pipeline. And what literature has shown is 30 to 60% of antibiotic usage we do is unnecessary, and 30 to 60% of the time we use inappropriate antibiotics, and 30 to 60% of the time we use suboptimal dosage of antibiotics, and all these together leads to a worsening of antibiotic resistance. And the inappropriate and usage of antibiotics is due to increased prescription of antibiotics by anyone and everyone, and erroneous prescription of antibiotics. And these are the references for that. If you look at the epidemiological data, it is shown that there is increase in the emergence of antibiotic resistance, and the usage of increase in the usage of antibiotics is shown to have direct proportion to the emergence and dissemination of resistant organisms. So the more antibiotic we use, the more is the emergence of resistant organisms, and more is the dissemination of resistant organisms. So the topic for the debate is that I will de-escalate antibiotics in culture negative sepsis. So then we need to understand what is the definition of sepsis. So again I show this figure. So sepsis is dysregulated host response to an infection. So that is what is the definition. So nowhere in the definition that you would see the word culture. So it is a dysregulated host response to an infection. And this life-threatening organ dysfunction due to dysregulated host response can be due to viral. So when you apply this definition and start giving antibiotics, then we may be ending up giving antibiotics to this viral infection, which may be causing exactly this life-threatening organ dysfunction due to dysregulated host response. Or this life-threatening organ dysfunction due to dysregulated response can happen due to other non-infectious conditions like pancreatitis, burns, or any other SIRS mechanism. Or dysregulated response and life-threatening organ dysfunction can happen due to drugs or transfusions that we would give, or in other non-infectious causes like IC bleeds or any other cerebrovascular event, or it can happen even due to progression of underlying disease like malignancy. So these are all some of the other clinical conditions which can all lead to life-threatening organ dysfunction. Like typically subarachnoid hemorrhage can lead to organ dysfunction. So it can, and that is due to inappropriate host response, because every host responds differently to these insults. And we understand that if you have to base your definition on dysregulated host response to infection, our ability to identify the infection by cultures is only 40%. So 60% of the time we are making erroneous decision on giving antibiotics where otherwise it may be non-infectious. That's my premise. And cultures, as we see, is only an adjunct in establishing diagnosis of sepsis. It is not the only one, because if you purely stick to the definition, The definition simply says it is life-threatening organ dysfunction due to dysregulated host response to infection. So I would say anyone using antibiotics to any of these conditions, viral or SARS or non-infectious, would tantamount to medical malpractice. So my argument is that we should be de-escalating when cultures are negative, because there may be multiple other reasons which may be causing that so-called spectrum of sepsis that we may have falsely identified. So let's look into the evidence. So this is one study which came from the Spanish group in 2013. So the title of the study is De-Escalation of Empiric Therapy. Empiric means they have started empirically thinking it is sepsis, is associated with lower mortality in patients with severe sepsis. So which means you de-escalate in patients with sepsis where you may have thought it is sepsis and started empirical antibiotic cultures, and if you stop, it led to better survival. So what it found is it was 628 patients, 219 patients were in de-escalation group where they started antibiotics thinking it is sepsis and then they stopped it. You saw that the protective factor was 0.58, which means the protective factor for 90-day mortality. So it offered protection and reduced the mortality in this group where it was stopped. And when you look at the positivity of blood cultures in de-escalation group and non-de-escalation, in both groups the blood culture positivity rate was only 38.3 and 38.6%. And in septic shock, the culture positivity was 50 in de-escalation group and 73.3 in non-de-escalation group. So what basically it says is that predominant group of patients were culture negative, but still in this group where they stopped antibiotics, I think that rendered a protective element for 90-day mortality. So let's look into the second study, de-escalation versus continuation of empiric antimicrobial treatment in severe sepsis. This was a multi-center, non-blinded, randomized, non-inferiority trial done by a French group in 9 ICUs in France. It was a multi-centric randomized controlled trial. So had 116 patients. So in 59 patients de-escalation was done, and 57 patients there was no de-escalation. And when they looked at the time frame between the sepsis onset and the study inclusion, in de-escalation group it was 3.2 days, in non-de-escalation it was 2.7 days. So when you look at the 90-day mortality, there was no difference in patient group where de-escalation was done and in when compared to non-de-escalation group where antibiotics were not de-escalated. So there was no difference in 90-day mortality, and ICU length of stay also was no different. And positivity, blood culture positivity was again compared to the previous study from the Spain, it was only 34% were blood culture. So basically they didn't see the only culture positivity. So where they felt there was no sepsis and culture was negative, they did stop and they found there was no difference in the 90-day mortality. Okay. So this is the meta-analysis by the Japanese group. So this is a non-inferiority meta-analysis where they have collated all the studies and seen whether de-escalation really made any detrimental outcomes. So if you look at it, so if the diamond doesn't move towards either of them, it stays at the center, clearly telling you that de-escalation would not lead to detrimental outcomes. So it was non-inferior. Okay. So this was another study. I think this is an important study which was done in neutropenic sepsis, because neutropenic sepsis is a group of patients where some would dread to stop antibiotics because they would want to continue antibiotics in neutropenic. So here this is a French group where they de-escalated even in neutropenic. De-escalation of antimicrobial treatment in neutropenic patients with severe sepsis. This was a prospective observational study involving patients with post-chemotherapy sepsis. So 101 patients were enrolled. So 44 were in de-escalation and 57 were in non-de-escalation. If you look at ICU mortality, so ICU mortality is found to be less in patients who were de-escalated based on the cultures, and in fact it was little more in patients who were non-de-escalated. And if you look at the hazard ratio at 30 days was 0.51, which means the risk of mortality was less in patients where de-escalation happened as opposed to the patients where no de-escalation happened. but hazard ratio at 1 year it was non-significant. And even if you see, culture positive was only in 63 out of 101 patients, which means even here they would not have based everything on culture. So they looked at the overall clinical picture and determined where they could have de-escalated. So clinic and 21 patients were started on antibiotics mainly based on clinical, and there were 17 patients in this group which had PUO, pyrexia of unknown origin. So pooling all the patients in ICU, if you do a meta-analysis, again you see that de-escalate, the diamond tends to move towards de-escalation. So again this forest plot reiterates that de-escalation is non-inferior to non-de-escalation. So, so if you watch for these evidences that have prevailed, so basically de-escalation was non-inferior, and if at all, if you look at the neutropenic group, it led to better outcomes if you de-escalated the antibiotics. So what we need to understand is signs and symptoms of infections can be very similar to other non-infectious causes in ICU, and we end up giving antibiotics for both these groups. So in this situation, I think procalcitonin is something that one could consider for discontinuation of antibiotics. So do we have evidence for that? So evidence comes from this pro-rata trial which came from the French group. So this is a landmark trial which included patients who were 67% of them were mechanically ventilated, 50% had community acquired infections, and 50% had hospital acquired infections. So it was a big study involving 621 ICUs. So here they looked at procalcitonin as a tool to stop antibiotics. So this is a group where procalcitonin was used to stop antibiotics. Control group is where antibiotics were continued. So when you look at the groups, day without antibiotics, so antibiotic free days was more where procalcitonin was used to stop antibiotics, which is good. And outcomes were found to be better in procalcitonin group. And this study came in 2010. This was followed by the most recent study which came in 2018 by the Switzerland group, Swiss group. So this is a much bigger study, 11 randomized controlled trials including 2252 patients, where again they used procalcitonin to stop antibiotics, and they found mortality was lesser if you use procalcitonin to stop antibiotics vis-a-vis comparing to the group where you continued antibiotics. And even the antibiotic duration was significantly less where procalcitonin was used to stop antibiotics as compared to the group where it was continued. So the take home message for my rebuttal is we need to reiterate, re-emphasize and reinvigorate the fact that we tend to inappropriately use antibiotics up to 60% of the times in our ICU. So that is something we need to curtail, and we have realized that inappropriate usage of antibiotics has a direct correlation or directly proportional to the emergence and dissemination of resistant infections. And we need to understand that based on the sepsis definition, we end up using antibiotics for all the non-infectious causes and viral causes or SARS or transmission of progression of underlying diseases, labeling them as sepsis, because all these conditions can lead to life-threatening organ dysfunction, and we label them as sepsis and continue to give antibiotics whilst we know only 30 to 40% of them may possibly have infection. And looking back at the evidence, we have seen two randomized controlled trials which show beneficial effects of de-escalation, and meta-analysis from Japan show that it is non-inferior to continuing antibiotics. And there were two large procalcitonin studies which justified its utility as an adjunct to de-escalate, where you could use procalcitonin. If you are in doubt, you are unsure whether it is sepsis and your cultures have come negative, use procalcitonin. If procalcitonin is not high, then you know it is not sepsis. You stop antibiotics, that will lead to better outcomes. So this was my rebuttal or my premise to the argument of why I would de-escalate. So my friend Sivakumar obviously argued as to why he would continue. My rebuttal for his argument was this. So this was a study which came from the Dutch group where they looked at uh, antibiotic that was used for 3 days versus 8 days. The reason why I'm putting up this study is because you would the topic or the debate of the topic for this debate is, I will de-escalate antibiotics in culture negative. De-escalate means where I may stop or I may bring down the antibiotic. The reason why this becomes important is, for the cultures to come it takes around 3 days. So which means after 3 days I would decide whether I stop or I de-escalate or I change or I stop antibiotics. This study becomes very important because this study was done in moderate to severe community acquired pneumonia, comparing 3 days versus 8 days of antibiotics. So we'll see what the result is. So it's a double blinded placebo randomized controlled trial. Primary outcome is to look at day 10 clinical success rate. Secondary outcome is to look at day 28 clinical success rate, and resolution of symptoms and radiological findings. So look at the results. A fantastic study. 119 patients. One group got only 3 days antibiotics. Because after 3 days, culture will come. If it's negative, you stop it. If culture is positive, you continue. So my argument is, at 3 days, look at the day 10 clinical success rate. It is 93%. Same as day 8 antibiotics. Day 28 clinical success rate is in fact better in 3 days antibiotics when compared to 8 day antibiotics. And day 10 radiological success rate, day 28 radiological success rate is absolutely similar. So my argument to my dear friend during my rebuttal was, since you would have anyway used for 3 days and you would have stopped, even remotely if it was sepsis due to bacterial, it would have treated based on this study that it would have been enough to eliminate the infection. So you are not really conferring any more advantage by continuing the antibiotics. So still I stand right in stopping antibiotics once my cultures are negative. So conclusion is, 3 days treatment is non-inferior to 8 days treatment as per this study. So, okay, so if my opponent is not convinced with that study, we need to look into this study which came from Lancet Infectious Disease, Ranjik et al. So he did a study where he found in hemodynamically stable patients, delayed initiation of antibiotics did not worsen mortality. Which means if someone is hemodynamically stable, they come to ICU and they're stable, you don't need to rush and give antibiotics, and it did not lead to worsening of mortality. In fact, what he found was, if antibiotics were given after you see the culture, which means in this study he has seen the cultures and started antibiotics after 3 days in patients who were hemodynamically stable, and he found there was reduced mortality, increase in the appropriateness of antibiotic usage, and reduced duration of antibiotic usage. So I would say, by not de-escalating antibiotics when cultures are negative, because there is 60% likely error in judgment, and this would lead to sacrilege, and it will increase the cost, increase the resistance, and it would increase the mortality. So by not de-escalating, my argument would be, you are burdening the patient with cost, and you are causing more harm to the environment by increasing the resistance, and if you have to vouch with this study, you may increase the mortality. And it would be sacrilege of gospels of 3 Ds, which is right dose, right duration, and de-escalation. So when you don't do this, we consider now any antibiotic stewardship revolves around 3 Ds: right dosage of the drug, right duration, and de-escalation. So by not doing de-escalation, so we are causing sacrilege of this gospel. So I would end my talk with this saying. See, when you look at what Lord Sri Krishna said to Arjuna in Bhagavad Gita, so renunciation of the objects of self sense gratification. I would say continuing antibiotics is basically sense gratifying. Absence of false ego. So basically you're egoistic, you don't want to stop antibiotics. Perception of evil of death, that probably is not applicable. Non-attachment to children, wife, home, and rest. So I would say we need to be non-attached to antibiotics. All these I thus declare to be true knowledge. So Lord Krishna said in Bhagavad Gita. So detachment does not mean you should own nothing. It means that nothing should own you. So I request all my friends that antibiotics should not own us. And have I walked the talk? So do I follow what I am telling here? So I have to show evidence that I do follow this in my practice. So this is my ICU chart, and you see this is the fever. So patient has a fever, and you see this patient has hypertension, ischemic heart disease, and has had a stroke. His reason for admission is stroke, and he has fever. Cultures were negative, And this is the chart I'm showing where we have stopped antibiotics, meropenem and vancomycin. So thank you very much. So it is the ability to bring out the best in others that make you a leader. So my intent is to get the best out of you.